My name is Mehta. I'm a retina specialist at the Gavin Herbert Eye Institute here at UC Irvine. I'm going to talk to you guys today about diabetic retinopathy. So this is the Diabetic Retinopathy Community Lecture Series. The thing about diabetes is that it can affect the eyes in a multitude of ways, and we're going to go over some of those right now and what to do about it. I have some disclosures of companies I get grants from and consulting with as well, some of which makes things that are related to diabetes. Now, vision loss in diabetes is from a lot of reasons. One of the most common reasons are cataracts. Cataracts are common for everybody. If you live long enough, you'll probably get a cataract. But if you have diabetes that is poorly controlled, the cataracts come much earlier. We'll have patients sometimes in their 30s who have cataracts from diabetes. Ischemia, or lack of blood flow in diabetes, can also cause vision loss. One of the more severe causes of vision loss is a form of glaucoma that happens in diabetics called neovascular glaucoma. This is when new blood vessels block the drainage canals of the eye and basically allows the pressure of the eye to go so high it damages the optic nerve, such that the signals from the eye can never make it to the brain. The thing that I deal with most is called diabetic retinopathy. And diabetic retinopathy can cause vision loss from three general ways. There are more, but these are the three most common. The most common is called DME, or diabetic macular edema. This is swelling of the center of the retina. When the center of the retina is swollen, that affects the photoreceptors, or the retinal cells that absorb light. It prevents them from absorbing that light well, so they don't see as well because of that. Next would be a vitreous hemorrhage, which is bleeding in the back of the eye. When you bleed in the back of your eye is full of blood, and so the blood is blocking the light from getting to your photoreceptors. The next would be traction, or pulling on the retina, because like before with the neovascular glaucoma, you can develop neovascularization of the retina as well. And these neovascular membranes, we call them, are scar tissue sheets that grow across the retina, and they will pull on the retina, and it'll distort things that people see, sometimes so bad it causes it to rip and kills the cells. And that is obviously very bad as well. So diabetic retinopathy is the leading cause of blindness in working age people in the United States. Even in patients who do everything right, at least 5% will benefit from surgery or procedures for diabetic retinopathy. These are patients who are well-controlled diabetics. Our goal for patients is to have a hemoglobin A1C less than 7%, control their blood pressure, and do not smoke. Ultimately, diabetes is a disease of blood vessels. Dr. Thakkar is going to go into more detail about the medicine of diabetes and the medical side of how it affects the whole body. But all of this affects the eyes because the retina is all nerve tissue. It's basically a part of the brain that can absorb light and see. And so controlling the blood sugar helps those patients by giving them good quality blood vessels that allows the cells to function. So when vision loss comes from the diabetic retinopathy, that's when the lining of the blood vessels in the eye become damaged by the sugar from the diabetes. These blood vessels will leak into the retina, causing it to swell. The body tries to fix this by growing new blood vessels. Now, it's fine for your arm or your shoulder or even your heart to develop new blood vessels when blood vessels are damaged. But new blood vessels in the eye don't work as well because the eye needs to be transparent so the light can get to the photoreceptors. So these new blood vessels will bleed and they'll form a scar, and the scar can damage the retina, causing blurry and distorted vision. Now, the symptoms of diabetic retinopathy can be completely asymptomatic, meaning you won't have any symptoms. But sometimes you will get symptoms even before it's very advanced, but more often than not, people don't notice it until it becomes an advanced stage disease. There's usually no pain unless the pressure goes up very high. And early on, you might not notice decreased vision because it might happen in one eye first, and your other eye may be dominant to the point where you don't notice that the worst eye was significantly bad. And over time, the vision can get blurry, distorted, or even dark. Oftentimes, first people will notice things like color differences are not as apparent to them. We call this a loss of contrast sensitivity. This can happen gradually or suddenly. You can become blind in one or both eyes, and that is obviously something we want to avoid. Now, in diabetic retinopathy, we typically divide it into two different sections. There's non-proliferative diabetic retinopathy, or NPDR, and proliferative diabetic retinopathy, or PDR. In this context, proliferative means growing new blood vessels. We call this neovascularization. It's a long word that means new blood vessels. And so when you grow new blood vessels, like I mentioned, they bleed and they cause problems. Now, we have many treatments for diabetic retinopathy, but the first, foremost, will always be controlling the blood sugar. Next, we want to control blood pressure and cholesterol, and definitely not smoke. You may have heard that smoking is bad for you. This is why. Because smoking damages blood vessels, and ultimately, diabetes damages blood vessels. So you don't want to help the damage to blood vessels anymore by smoking. We will also often do injections in the or around the eye of medicines to help these diseases and to help people see better. Sometimes we'll do lasers and sometimes we'll do surgery, and we'll often do a combination of all three. So this is a normal eye in cross section, like you're looking at me from the side through my ear. And the front here, there's a contact lens on the eye in purple. And then you have the cornea and these little, let me see if I can get my pointer to work here. That's not working for me. So the front of the eye is the cornea. Then we have the iris, and behind that, this oval shape is the lens, the natural lens of the eye. Behind that, this big space here is called the vitreous cavity. And behind that, lining the wall of the eye, we have the retina. That little stick coming out the back right is the optic nerve. Just above the optic nerve, you see a little divot in the back wall of the eye. That is called the fovea. That's the center of the vision. That little divot is the only part of your eye that can read well enough or see well enough to read. And so this is the most important part of the eye. Next, we have what the retina looks like when we look straight at it. So this is what a normal retina looks. When I look inside your eye, this is what I see. The bright yellow thing is the optic nerve, and you see the blood vessels coming out of it. So this is the optic nerve here. And then we also have the dark ones here are veins, and the lighter ones are arterioles, or little arteries. And the center of the retina, right here in the middle, is the fovea, or the center of the vision. In non-proliferative diabetic retinopathy, we see changes in the retina. And the difference between this eye and the last eye, whereas in this eye, we have microaneurysms, and you see these little yellow spots around them called exudates. That is protein from blood that is leaked out of that little aneurysm. And you see little hemorrhages on the side bleeding. We can see hemorrhages inside of the retina or on the surface of the retina in diabetes. Now, this is something called a fluorescein angiogram. Sometimes we'll put an IV in your arm in the clinic and inject a plant-based yellow dye. And this yellow dye leaks through the whole body and eventually gets to your eyes. And we use a black and white filter. And what this light shows is everything that's bright is blood. And so blood shouldn't be leaking out of the blood vessels. But when it does, it causes kind of a gray patchy area. And that's what we call leakage or swelling in the retina or edema. Some areas are darker, we call it ischemia, because there's no capillaries in that area. So you don't see any light gray background in those areas. Some of the areas are really bright, and those are little aneurysms because the blood kind of pools there and it can't really flow because it gets stuck in this little sac. That's what the aneurysms are. We also often do a scan called an OCT scan, or optical coherence tomography. In an OCT scan, we look at the retina in cross section. The picture from before is a front-facing picture or an en face picture. If we look at it in cross-section, kind of like an ultrasound, we're using a laser instead, That gives us very fine detail to look at the thickness of the retina, specifically in the center and the fovea. The picture on the bottom shows a normal foveal depression. There's supposed to be a little divot there. That's a normal eye. The one above you can see is much thicker and it has these large black empty spaces and a bright colored space right inside of the black space right in the middle. And that is blood. So the blood is denser, so the laser bounces off of it. And fluid or water doesn't reflect light, and so it goes through it. So it's a dark image on these pictures. So to treat diabetic macular edema, we'll often inject medications in the eye. The place we inject is through the pars plana for intravitreal injections, and sometimes we'll inject underneath or above the eye in something called the subtenon space. This is through the conjunctiva or the wrapping of the eye, and we'll go across that area either around the eye or through the pars plana into the eye, into the vitreous cavity. The reason we can inject through the pars plana is you can see from this drawing that the retina doesn't reach all the way to the front to the lens. The little black area that has no brown area next to it is called the pars plana. And that's an area that has very few blood vessels and no nerve tissue, so it won't be damaged by putting a needle through it. So then we can inject into that big cavity. And that's a nice place for us to inject medications that'll just sit there and work on the eye for us. This way we can do a lower volume and get a higher concentration where we want it to be and not elsewhere. The types of injections we do are a few. One of the most common type is a medication style called anti-VEGF or vasoendothelial growth factor. By blocking VEGF with all of these different medicines, we can cause the body to seal up those leakage areas in the capillaries that have been damaged and then absorb the fluid that's causing the swelling in the eye. VEGF also is the factor that causes the growth of new blood vessels. So by blocking that factor, the new blood vessels stop growing, and sometimes they'll even retract and regress. So these medications are a complete game changer for diabetic control and the control of other diseases as well. When I was in medical school, we didn't have these. But when I started my training, they started coming and started being used in diabetes. And we had massive improvements in people's vision as a result of these medications. We'll also inject steroids either in or around the eye. And these steroids can also help because diabetes is also an inflammatory disease. It releases a lot of inflammatory factors, only one of which is VEGF, but there are other factors as well. And steroids can help block a lot of those different factors. And there's several different medications we'll use to control the diabetes damage in the eye, but with using steroids. One thing we need to be careful of is steroids can raise the blood sugar. So we prefer to put a small amount next to the eye rather than having patients take it, a larger dose through their mouth. Now, this is the patient who had proliferative diabetic retinopathy. If you look at this image where the arrow is pointing, if you look very closely, there's a very fine network of blood vessels that are all neovascularization. And this patient is a type 1 diabetic. Type 1 diabetes is more dangerous than type 2 because the body doesn't produce any insulin. And so as a result, the blood sugar is more labile. It's able to get very much out of control and cause a lot of problems. You can also see on this image, there's some black little lines underneath. That's the eyelashes that you're seeing. And there's horizontal red areas. That's actually blood in the vitreous cavity. We call that a vitreous hemorrhage. So this patient is about to have a bad problem. So we want to apply laser to this eye. We call it PRP or pan-retinal photocoagulation. Big words for laser. And what that does is we treat the area in the periphery of the vision that has the least blood flow, and we essentially kill off dead and dying retina or non-functional retina in order to save the central vision. So by doing that, we decrease the demand of VEGF for the body, so the body doesn't release this factor and doesn't grow new blood vessels. But this patient missed their appointment. When they missed their appointment, their whole eye became full of blood, and the patient could not see anything. Before, this patient's vision was around 20/60, where 20/20 is normal. The higher second number, the worse it is. So you want the first number to be 20 and the second number to be as close to 20 as possible. What that means is that what a normal person can see at 20 feet, this patient can see at 20 feet. Or in this case, what a normal person can see at 60 feet, this patient has to be 20 feet away to be able to see it. So they have to be much closer to see what a normal person can see. But now with this much blood, the patient can't see anything, can barely count the fingers in front of their face. And they can't read even the big E on the chart because the blood is blocking the view. It's just like you can't see the retina can't see out as well. So in the back of the eye, this is an ultrasound. So just like ultrasounds we do for pregnant women, this ultrasound of the eye called the B scan, and we can see in cross section across the eye. And you can see this bright stuff here. That's all blood that's swirling around in the back in this patient. So when we do an angiogram on this patient, they progress over time. You see all of these bright areas in the bottom picture on the right side here. That is all neovascularization. So when you see this neovascularization, that is a large area of new blood vessels. So this patient, even though the vision is pretty good, 20/60, they're about to have a major problem. You can see up above the OCT scan doesn't have any edema in the retina, but there's no dip there because there's a little scar tissue membrane at the top, kind of crunching the center of the vision. So that's why the vision is not 20/20. Even though there's no edema, it's from that what we call epiretinal membrane. But these neovascular membranes that are in the periphery, these are very bad. So sometimes, even despite doing everything, doing the laser, controlling everything you can, they still get worse. So this patient had laser. You see the laser treatments. There's a little arrow there with the little black spots. Those black spots were laser spots. So despite the laser, they still developed this scar tissue membrane. That's the white grayish lines on the image of the retina. And these membranes are causing traction. Because remember, the eye is a ball. It wants to be a curved surface, but the shortest distance between 2 points is a straight line. And so the scar tissue membrane is pulling the retina taut and it's causing it to stretch. So if you look at the OCT scan on the side, there's no divot. There's just these stretch marks of the swelling. So sometimes the swelling is due to leakage of fluid causing the retina to swell by pushing from the inside out, or sometimes there's traction pulling from the outside, and that pulls it up, and that can stretch the retina and affect the vision as well. But in this patient, I did surgery. I removed all of those tractional membranes and I added more laser, and they were able to get back to their baseline vision. And this is what the eye looked like afterwards. So with good treatment that's quick enough, we're able to restore vision in patients that have lost all their vision from diabetic retinopathy. But it's very important that the patients control their sugars because no matter what I do, if the patient doesn't control their sugar, it's just going to attack itself again, and the patient's going to lose vision. So in summary, now that we have better control that Dr. Thakkar is going to help us with, and better medicines, tools, and technology, it leads to better vision in these patients. This is our retina team. There are 6 of us right now: Dr. Cooperman, Dr. Riazi, that's me, Dr. Liu, Dr. Mishra, and Dr. Brown. The 6 of us all manage patients with diabetic retinopathy and all eye diseases of the retina. Thank you. I'd like to introduce Dr. Aditi Thakkar.
All right. Hi, everyone. My name is Aditi Thakkar. I'm an endocrinologist here at UCI. And today I'd like to talk about the regulation of blood sugars through lifestyle. All right. So before we talk about lifestyle changes, I want to go over the diagnostic criteria for diabetes. So to diagnose diabetes, you need 2 out of these 4 criteria. So the A1C, which is a blood test that tells you gives you a 3-month average of your blood sugars, an A1C greater than 6.5%, a fasting blood glucose greater than 126 milligrams per deciliter. So this is usually about 8 hours fasting. Um, your blood glucose after a 75-gram oral glucose tolerance test, which is kind of a liquid solution that they give you at the lab, and they check your glucose 2 hours later. So if the glucose is greater than 200, that would help with diagnosis of diabetes. Or if you have a random plasma glucose test, with symptoms of high blood sugar, which means symptoms are increased thirst, increased hunger, um, and let's say the glucose is greater than 200. When we say random, we mean irrespective of uh, when you had food. So if that's greater than 200, that would meet the diagnostic criteria. So you need two out of these four criteria to be diagnosed with diabetes. For pre-diabetes, we have A1C of 5.7 to 6.4, a fasting plasma glucose of 100 to 125, the plasma glucose after a 75-gram oral glucose tolerance test of 140 to 199. Um, and here you just need one of these criteria to be called prediabetes. Now, uh, if you look at this graph here, you can see the pink line is retinopathy, the risk of retinopathy. And on here on this axis, you have the A1C. So you can see that as the A1C increases, uh, the risk of retinopathy increases. And so the goal, the optimal A1C goal for uh, to prevent complications like retinopathy is 6.5% or less than 7%, or a fasting plasma glucose less than 126. But about half the patients with diabetes have an A1C greater than 7%. And that's why I want to talk about how we can regulate our blood glucose besides medications. And this would help to reduce our risk of complication, reduce the risk of complications. Now, when I think about blood glucose regulation in the body, I think of it as a balance between the food glucose that's increasing through the food that's consumed, plus the glucose that's produced in the body, versus the glucose that's utilized and stored in the body. So first, let's focus our attention on diet, because this is heavy duty topic, very important. Okay. The American Diabetes Association are a set of guidelines that come out every year, and this is what most clinicians and doctors use to guide their management of diabetes. When the first American Diabetes Association guidelines came out in the 1980s, nutrition was only mentioned in a few sentences. Thankfully, we've come a long way. We've made a lot of changes in the way we talk about nutrition. Uh, Previously, just a few years ago, we used to think about uh, we had to focus on how many carbs to eat, fats, proteins, and micronutrients. But now we're trying to uh, talk more about eating patterns because in the end, people eat food, they don't eat nutrients, and you want to consider the totality of the food and the drinks that they're consuming. So the diets in general that the American Diabetes Association recommends for patients with diabetes are the Mediterranean style diet, low carbohydrate diets, vegetarian and plant-based diets, and then there's a specific diet called the dietary approach to stop hypertension for patients with high blood pressure. But essentially, the principles of this diet are the inclusion of non-starchy vegetables, whole fruits, legumes, lean proteins, whole grains, nuts and seeds, low-fat dairy or non-dairy alternatives. They recommend minimizing the consumption of red meat, sugar-sweetened beverages, sweets, refined grains, and processed and ultra-processed foods. I want to focus a little bit more on carbohydrates because I get asked this question a lot about how many carbs I should be eating as a diabetic, how to eat carbs to prevent what carbs should I eat to prevent glucose spikes? Because most of the rise in blood sugars after meals come from the digestion of carbohydrates, I think it's an important topic. So, what are carbohydrates? These are sugar molecules that are digested down into glucose by the body. There are three types of carbs. One is a simple carb. The second is complex carbs, which are starch. And then the third is fiber. So simple carbs is essentially sugar. It's broken down very rapidly by the body and it causes a very sharp rise in glucose. So some examples can be things like corn syrup, honey, fruit juices. Uh, Fruit can also be considered a simple carb, but when you have a whole fruit, including uh, the skin, You would also consider it part of the fiber group because fruit has some fiber too. So these groups are not mutually exclusive. The second group is starch. So these are longer chains of sugar molecules, which take more time for your body to break down. Examples can be grains or rice, potatoes, beans, lentils. And thirdly, we have fiber, which is a indigestible part of plant food that's really important for digestion. It keeps you full and prevents glucose spikes. So some examples would be vegetables, fruits, legumes, pulses, whole grains, and seeds. Now, when you're consuming carbs, the goal is to choose carbs that are nutrient dense and low in added sugars, sodium, and unhealthy fats. The American Diabetes Association does not uh, give an ideal carbohydrate goal for diabetics. They focus more on the quality of carbs rather than the quantity, and we'll talk more about that. But there is a fiber goal for our diabetics, and it amounts to about 25 to 35 grams per day for most people. One thing I just want to highlight is to read, please read labels. The total carbs that you see in when you're, let's say, reading a nutrition label, for example, here it's bread, actually refers to the totality of all three carbs. So they have the dietary fiber along with the sugars. Um, so that tells you the total amount of carbs. Now, anything that has about 4 to 5 grams of fiber per serving is actually considered a good source of fiber. So you may want to consume those. The other thing is please look at serving sizes because you want to know whether what you're consuming actually equals the amount here. Because often uh, some places will put a smaller serving size or a much larger serving size. So you want to get accurate information. Now, what sort of carbs should you be choosing? So eat the most of whole, unprocessed, non-starchy vegetables. For example, veggies like lettuce, cucumbers, broccoli. They have a lot of fiber and very little carbohydrates, so you have less impact on your blood glucose. Eat some of whole, minimally processed carbohydrate foods. So this includes fruits, whole grains, and just as an aside, the difference between a whole grain versus a refined grain is that the whole grain contains the outer layer, the outer capsule, the bran, that's really rich in fiber and it slows down digestion of the carb. It also contains the germ, which is the nutrient-rich core that contains all the phytonutrients, the antioxidants, um, along with the starchy part, which is the endosperm. The refined grain removes the bran, it removes the germ, and so you're just left with the starch, and that's why a lot of the refined carbohydrates that we eat, for example, cereals, uh, they may be fortified but that doesn't fortified with nutrients, but they don't replace all the nutrients that are removed during the processing of uh, of that food. So other going back to these whole minimally processed carbs, starchy vegetables like corn, potatoes, and then beans and lentils. Eat the least of refined, highly processed carbohydrate foods or foods with added sugar. So, for example, you have sugary drinks, refined grains like white bread, white rice, sweets and snacks like cakes, cookies, all that junk food. Um, these have the least amount of fiber. They are very high in added sugar, preservatives, fat, and they really will increase your glucose. And they're very low in nutritional value. Another thing you could consider is the glycemic index of food. What is a glycemic index? This is a way of ranking carbohydrate-containing foods based on how quick they're going to increase the blood glucose levels over a period of time. Usually it's about 2 hours after consumption of that food. Um, so if you look at this chart that I have, lower glycemic index foods usually less than 55, medium is 56 to 69, and high glycemic index foods are greater than 70. So you can see vegetables have the lowest glycemic index of all these groups. Um, then dairy is also usually lower in the glycemic index. But if you look at grains, they have the highest glycemic index. And if you actually look at the difference between the whole grains and the white bread, you can see that this is probably going to spike up your blood sugar a lot faster than the whole wheat bread. And that's because of the lack of fiber in the white bread. But remember, the glycemic index should not be your end all and be all uh, because there are some limitations. Glycemic index does not take into account the quantity of, or the quantity of the serving that you're going to be having, or protein, fat, or micronutrient density. So, for example, watermelon has a really high glycemic index of 72. But a serving of watermelon has such little carbs because of its very high water content that its actual impact on the glucose when you have a smaller serving is actually not going to be very much or as high as that glycemic index would suggest. So it's a useful tool, but I wouldn't rely completely on it. So in summary, when it comes to the diet, balanced diet is key. Keep both the quantity and quality of carbs in mind. Try to stick to minimally processed, less refined carbs without added sugars. Read nutrition labels, and the glycemic index could be a useful tool for glucose management. Now, let's talk about ways in which glucose is produced in the body and strategies to control that through behavior. So now glucose is produced in the liver. Most of the glucose production occurs in the liver. The body produces glucose through two main processes. One is the breakdown of stored glycogen, called glycogenolysis, and the other is creating new glucose from the substrates of amino acid, lactate, and fat byproducts called gluconeogenesis. These processes are under the influence of certain hormones like cortisol, epinephrine, and glucagon. Now, a time when this process would be very useful would be when you're fasting and you don't have access to a glucose source. So in order to fuel the brain, your liver can just break down glycogen stores or build new glucose to as fuel for the brain. But these hormones get activated in times of stress or when you're not getting enough sleep. And therefore, when you're under stress or you're having a lot of sleeping issues, you can have increase in glucose levels irrespective of what you're eating or your activity levels. And I get this question a lot with patients where they may be eating the same thing on two different days, but their glucose reacts very differently. And so it's important to remember that that food is not the only thing that impacts your glucose. So, in summary, for glucose production, try to adopt healthy coping mechanisms for stress, and your sleep quality matters. So, try to get at least 6 to 8 hours of uninterrupted sleep. Now, let's talk about the other end of our scale. So, glucose utilization and how glucose is stored. So, in this diagram, if you look towards the left, that yellow organ is the pancreas. After you eat, glucose, which are the blue dots, gets released into the bloodstream, and your pancreas responds by producing insulin. The insulin is going to push or move glucose into the cells. This is how things are functioning in a person who doesn't have any glucose regulation issues. But in patients with diabetes, most forms of diabetes, you have either the pancreas producing less insulin, um, and so there's not enough insulin to push glucose into the cells, or you have something called insulin resistance occurring, where the cells that are supposed to be taking up the glucose, they become more resistant to the effects of insulin. So the same amount of insulin is not able to move enough glucose into the cells. And insulin resistance is the main mechanism that underlies type 2 diabetes. You actually also have dysfunction of the certain cells of the pancreas that produce insulin in type 2 diabetes, but the main underlying process is insulin resistance. Now, we just understood how insulin helps to move glucose into the cells, but let's see how exercise affects this process of glucose uptake. When you eat, the pancreas secretes insulin, we just said that, which allows glucose to be taken up by cells like the muscle. let's say you were to do a little bit of exercise, light activity, maybe a walk, uh, after you ate, this muscle contraction actually causes a glucose transporter called GLUT4 to move to the outside of the cell membrane to allow glucose uptake to occur. And this is completely independent of insulin. This occurs on its own because of the muscle contraction. And so, activity can play an important role in glucose clearance from the blood. And if you were to take a short walk after you eat, it could be effective to manage post-meal glucose spikes. Now, we talked about glucose utilization. What about glucose storage? So, after you eat, glucose was taken up by the cells. We just said that. Uh, what happens to that excess glucose? It's stored primarily in the liver and the skeletal muscles as glycogen. But once the glycogen stores are full, excess glucose gets converted into triglycerides, which is a type of fat, and it gets stored as fat tissue or adipose tissue. So you may have heard the term fatty liver. So some of the fatty liver can develop due to this glucose conversion into the fat stores around the liver. So this is another reason to avoid really high glucose spikes because you want to avoid these downstream metabolic effects on your cholesterol levels as well as the liver. So um, in conclusion here, insulin is a hormone that induces glucose uptake into the metabolic organs like the muscle. And exercise can be an insulin-independent mechanism for glucose uptake in the muscle. And like I said, insulin excess glucose promotes increase in triglycerides and fat deposition in organs such as the liver, causing fatty liver. This is actually a really nice diagram that is in the the latest American Diabetes Association guidelines, where they talk a lot about the physical behaviors that can support, here's this type 2 diabetes, but I think it's really helpful for all diabetics, apart from diet. So these are the five S's, and four of them include exercise. So they are stepping. So they're actually just talking about walking or increasing your steps. It's really important for cardiovascular health, and it can even improve or increase your life expectancy by 4 years, just a 5 to 6 minute brisk intensity walk per day. The second S is sitting or breaking up prolonged sitting. So try to stand or slow walk at least every 30 minutes of sitting that you're doing. Then sweating. Try to get in at least 150 minutes of moderate intensity activity per week, or 75 minutes of vigorous intensity activity per week. Try to spread this out over 3 days. Try not to have more than 2 days of inactivity. And then that leads us to our fourth S, which is strengthening. Resistance training actually improves insulin sensitivity and improves your blood glucose. So you try to incorporate about 2 days of some form of resistance activity if you can. So for example, weights or resistance bands would be great. And then the fifth S is sleep. I mentioned this before, but sleep is really important. Trying to get at least 6 to 8 hours of uninterrupted sleep every day is important. And I just wanted to bring up this website that's provided by the American Diabetes Association. There are recipes, there's meal planning resources, and cooking classes. So it's a great website. There's a QR code here. I'm just gonna stop for a few seconds in case you want the QR code. All right, and just to plug in for our diabetes classes, these are over Zoom. These are UCI diabetes classes, and these are led by our diabetes educators, and they go over a lot of topics that are really helpful. And the QR code will lead to the website where you can sign up, or you can contact our education coordinator. but these are really good classes. All right, and that is it. Thank you, everyone, for listening.